Greetings to all who are partaking in World Pride 2021, a celebration of equality and diversity taking place in the cities of Copenhagen and Malmö. My name is Dr. Jose Zuniga, and I serve as president of the International Association of Providers of AIDS Care, or Ipac, one of the core partners of the Fast Track Cities initiative. We are here today in conjunction with World Pride 2021 to officially launch LGBTI+ Health Equity, a global report of 50 Fast Track cities. This report offers an assessment of this critical issue across Fast Track cities in every region of the world, including Copenhagen, which joined the network in June 2021. The Fast Track Cities initiative was launched on World AIDS Day 2014 as a collaboration between Ipac, UNAIDS, UN Habitat, in the city of Paris. Today, more than 350 cities worldwide have signed the Paris Declaration on Fast Track Cities, committing themselves to act locally on the global goal of ending AIDS as a public health threat by 2030. In addition to attaining measurable HIV programmatic targets, local action includes ending stigma against those who are living with or affected by HIV, among whom LGBTQ populations are disproportionately represented. Last year, Ipac decided to launch a global assessment on LGBTQ health equity across a subset of Fast Track cities. With grant support from Vive Healthcare, we designed an assessment mechanism whose results are meant to inform community stakeholders in current and prospective Fast Track cities about how to better serve their diverse LGBT communities. By providing a snapshot of the LGBT health equity situation in urban settings, we hope to bring attention to the idea of building back better, notably as the COVID-19 pandemic served to exacerbate long-standing inequities, including in relation to health. While LGBT populations and their needs vary between cities, research has consistently shown these individuals to be key in HIV responses, which is a primary area of focus for the Fast Track Cities initiative. But we know that HIV-related disparities among this population cannot be addressed in isolation. Instead, we must tackle the underlying stigma, discrimination, and socioeconomic vulnerabilities that LGBT people face if we want to meaningfully address overall health inequities. This reality has come into sharp focus during the COVID-19 pandemic, which was a powerful and sobering backdrop for this entire investigation. Very few governments included sexual orientation and gender identity in COVID-19 surveillance relating to cases, outcomes, or vaccinations. Therefore, data on LGBT populations in COVID-19 are quite limited. However, various health authorities have noted that because of the vast underlying health inequities that this population faces, we can expect them to have unique vulnerabilities and particular needs with respect to the COVID-19 pandemic. We also witnessed over the past 14+ months how the LGBT community's sources of resilience were stretched to the breaking point during the COVID-19 pandemic. Formal and informal social spaces were shut down. Health services were difficult or impossible to access, and a population that was already less likely to be employed and stably housed lost socioeconomic opportunities at a higher rate than others, according to several studies. In sum, if we needed any more proof that LGBT equity must be a priority in public health and the health systems upon which LGBT communities rely for services, 2020 delivered abundant evidence in a devastating way. To remedy the inequities facing LGBT people, we must take the broadest view possible of health and social determinants thereof. To that effect, the research work we undertook to produce the LGBTI Health Equity Report included 4 wide-reaching health indicator domains: health outcomes, such as prevalence of HIV, mental health conditions, and non-communicable diseases; socioeconomic factors, including rates of employment and housing stability; community trauma, such as discrimination and criminal justice issues; and community resiliency, including levels of civic engagement and resource availability. Additionally, we used 2 distinct research methods to investigate these areas. First, data assessments were conducted for the 50 highlighted Fast Track cities. These assessments included reviews of published literature, public health data, laws, and policies. And second, a survey was fielded among more than 250 key informants from across the 50 fast-track cities, asking for their expert opinions regarding LGBT issues in their communities related to the 4 domains. Overall, the results are clear that we have a long way to go to achieve LGBT health equity in urban settings, and that is true in every setting, including more mature LGBT communities, those with better protections, including laws and policies, and those that are better resourced to deliver LGBT-friendly services. In topics such as the availability of quality LGBT care and LGBT-inclusive data, the HIV field stood out as a leader. Thus, while there is still much room for improvement, we should also look to urban HIV responses as examples and leverage their long-standing networks to build out more holistic LGBT systems of care and social support. But despite glimmers of good news in this report, including with respect to the remarkable resilience of LGBT communities, we must take the report's findings as a call to action to both proactively and holistically tackle LGBT inequities. To that end, the report concludes with detailed recommendations for everyone who can have an impact on urban LGBT health: city and municipal leaders, public health professionals, clinical and service providers, and community organizations, but also critical partners at national, regional, and international levels. To highlight just a few of the top-line recommendations: prioritize inequities within LGBT communities. As you will hear in just a few minutes, racial and ethnic minorities, transgender and non-binary individuals, and other subpopulations within LGBT communities face compounded inequities. We must make sure that we take an intersectional approach to addressing LGBT health equity if we are to succeed. Additionally, we should view health holistically and address the underlying social determinants of health that affect LGBT populations. Key informants indicated many gaps in access to employment, food, and housing, as well as issues with criminal justice systems. Passing non-discrimination laws, while important, will not get us to equity if we ignore existing and long-standing racial and socioeconomic challenges facing LGBT individuals. And as a final example, data collection systems must be reformed to include sexual orientation and gender identity indicators as a matter of course. Our research identified numerous gaps in disaggregated data, a trend that held throughout the world, and this only serves to obscure the needs of LGBT populations. Not all of these and our other recommendations can be achieved at the city or municipal levels alone. But through the Fast Track Cities initiative, we have witnessed a new city multilateralism emerge, in which urban leaders have a seat at the global public health table and work with national and global actors to effect change. We hope that the city public health multilateralism in full display across the Fast Track Cities network can serve as a model for how the 50 Fast Track cities included in this report and all other cities and municipalities can act as forces of change for LGBT health equity. Now I would like to introduce one of my fellow co-authors, Corey Prashniak-Rincon, who will walk us through some of the report's findings. After that, we will hear from several leaders in LGBT health equity from around the world. And finally, we will have a live question and answer session to complete today's session.
Here's a brief summary of our findings. On a scale of 1 being poor and 5 being excellent, key informants rated the quality of life for LGBTI+ people in their city with a median score of 3 and a mean of 3.2. That falls right in the middle of the scale, which demonstrates that overall we have a long way to go on LGBTI+ quality of life. Regarding access to care, on the same 1 to 5 scale, key informants gave a score of 3 to the availability of LGBTI+ knowledgeable and competent providers. Mental health care and gender-affirming care were rated worse, with scores of about 2.7 each. On the other hand, the availability of low-cost, low-barrier HIV services rated much better, with over a 3.8 average. The relative quality of HIV services was matched by relatively good availability of data on HIV when it came to our assessments, which were led by Professor Matthew Mimiaga. Data showed a clear disparity of HIV prevalence among sexual minority men, and wherever data was available, trans women had even higher rates. Many cities had data showing disparities of other STIs among sexual minority men as well, But beyond that, sexual health data on other parts of the LGBTI+ community and data overall on conditions such as non-communicable diseases were almost entirely unavailable or incomplete. With respect to mental health, a majority of cities had data on the prevalence of depression among sexual minority men, which showed a disproportionate rate among this population. But that was the only data point available in a majority of cities. Many cities also had data showing that drug and alcohol use was higher among LGBTI+ populations, with minority stress, and therefore stigma and discrimination, being the main root causes. These mental and behavioral health disparities put into context how troubling it is that our key informants gave poor ratings to mental health care in their cities. Turning to socioeconomic factors, our assessments found no city-specific population-based data on topics such as employment, housing, and food security among LGBTI+ populations. However, our key informants revealed that these are sources of major concern. When asked whether it was a challenge for LGBTI+ people to find and maintain adequate employment and housing, less than 5% said it was not a problem in their city. In contrast, 71% said employment was a serious or moderate challenge, and 79% said housing was a serious or moderate challenge, with the balance saying that these were minor problems. Access to food was rated slightly less of a problem, but still, only 20% said it was not a problem at all. These areas comprise key social determinants of health and must be addressed in order to improve LGBTI+ health equity. And yet, key informants indicated that actors such as local governments, nonprofits, and businesses were not yet doing enough to address these inequities. The response to housing was rated the worst, despite being not the area where help was needed the most. Discrimination is one of the key causes of these socioeconomic inequities. According to our assessments, non-discrimination laws were less common in the African cities included in this study than they were in the other regions, with the exception of Durban, South Africa. Key informants indicated that discrimination on the basis of gender identity was the biggest problem, followed by discrimination related to HIV, and finally, sexual orientation. Only 6% said gender identity discrimination was not a problem at all, 20% said it was a minor problem, and 74% said that it was a moderate or severe problem. This finding reiterates the importance of prioritizing gender minorities to achieve equity. Several criminal justice issues were also explored in the report. In a few cities, same-sex relationships were criminalized directly or through laws supposedly relating to public decency or morality. Additionally, in 44 out of the 50 cities, sex work was illegal, which is concerning for LGBTI+ equity given the community's overrepresentation in this field and the possibility of them being targeted. Similarly, most cities had laws criminalizing the transmission of HIV or non-disclosure of HIV status. According to key informants, while few said that criminal justice issues were not a problem at all, they were rated slightly less of a concern than were socioeconomic disparities and discrimination. Particularly troubling was that 89% said there was a disproportionate impact of criminal justice issues on LGBTI+ racial or ethnic minorities. The criminalization of sex work and mistreatment of sex workers was also rated as a top concern, more so than the overall treatment of LGBTI+ people in law enforcement. In terms of community resiliency, many cities had LGBTI+ social spaces and formal public engagement through means such as LGBTI+ advisory boards, city liaisons, or public reports. These were particularly common in the Americas and Europe. However, key informants indicated that much more is needed to engage and support their local communities. Our survey found that nonprofits were, by far, the best at engaging in productive and respectful dialogue with LGBTI+ people, which could help foster and build resiliency. Nonprofits scored about a 4 on a 1 to 5 scale, while providers, city governments, and the private sector each scored about a 3. This shows that nonprofits are the local leaders on engagement and could help build bridges between LGBTI+ people and other sectors. Finally, while there is much more in the full report, here are some city-specific comparisons based on 15 of the 50 cities in a preliminary analysis. The overall quality of life for LGBTI+ individuals on a 1 to 5 scale ranged from a low of 2.2 in Tokyo, with Kampala and Athens being the next two lowest scoring cities, to a high of 4 in New York, with Lisbon and Melbourne being the runners-up. With respect to housing, which was the biggest socioeconomic challenge identified in the report, Melbourne was the city in which housing access was least problematic, which tracks with its high reported quality of life. However, respondents in Tokyo gave their city the second best score on housing access, despite the city's low overall quality of life score. In fact, several of the cities with lower quality of life scores, such as Kampala and Kingston, reported housing as being a relatively minor concern. On the other hand, the US cities, New York, Charleston, Phoenix, Denver, and San Francisco, all reported major problems with LGBTI+ housing access. Finally, with respect to another top issue, discrimination based on gender identity, the two cities with the lowest self-reported discrimination were New York and our host city for today's event, Copenhagen. The city with the highest levels of gender identity-based discrimination were Kingston and Kampala, which seems consistent with their quality of life scores and limited legal protections according to our assessments. However, even in many of the cities with high overall quality of life scores and good legal protections in place, like Melbourne, Lisbon, and San Francisco, gender identity-based discrimination was still ranked as one of the biggest problems. For additional details, I would encourage everyone to read our full report, which includes regional analyses and comparisons, as well as snapshots on LGBTI+ health equity from among the 50 fast-track cities that were included in the survey and assessments.
My sincere gratitude to Corey and Matthew for their descriptive analysis of their research, and to our key informants from across the Fast Track Cities network. I am pleased to welcome several leaders in LGBT health equity to offer their response to the report's summary findings and their opinions regarding the status of LGBT health equity in the regions they serve.
It wasn't that long ago that homosexuality and trans identities were considered medical anomalies in need of treatment. Homosexuality was removed from the International Classification of Diseases in 1990, and trans identities were removed from the same list in 2019. But perceptions of our identities as disorders persist around the world. Let me start with the most basic issue when it comes to healthcare for LGBTIQ people: access. Even in places with strong legal and policy protections, LGBTIQ people experience discrimination, hateful attitudes, and even refusal of services by healthcare providers. Too often, medical professionals are not informed or have little experience with LGBTIQ healthcare. Trans people, for example, are too often placed in wards not corresponding to their gender identity. Then there's the fear of being outed, which is especially potent in countries which continue to criminalize same-sex relations, as being outed can result in being arrested. Why is all this important? Because fear of discrimination, lack of knowledge, and absence of trust leads to LGBTIQ people not seeking medical help. That, in turn, can result in untreated health issues, reliance on self-medication, and overall lower levels of health among LGBTIQ people than the general population. One example from Outright's research about the effects of the COVID pandemic on LGBTIQ people globally illustrates this. One of the people we interviewed was a trans woman in Russia, and she told us, "I will call the ambulance only if I am suffocating, only if I feel a very real threat to my life. I'm afraid that if I get hospitalized, they will notify my family and out me. I'm afraid that I will be placed in the men's ward and that the doctors will not understand my situation, that they will treat me worse than others." Not only do we risk facing discrimination when LGBTIQ people seek medical help, but the very professionals supposed to help us can be ones who inflict harmful, ineffective practices on us. In Outright's report, Harmful Treatment, about the global prevalence of so-called conversion therapy, we documented that healthcare providers are among the top promoters and perpetrators of these harmful practices. They are designed to change, to convert, to suppress sexual orientation and gender identities beyond the heterosexual and binary norm, including by psychologically or physically abusive means, such as electroshock or even so-called corrective rape. Such practices never work. They're recognized to be tantamount to torture and instead cause deep, lasting trauma that affects every realm of life. In essence, they constitute the cisgender heteronormative indoctrination. The fact that the very people who should be helping us attain the highest standard of health can take part in inflicting these harms is horrifying. For some members of our community, healthcare also results in unnecessary, harmful, and non-consensual physical interventions. Intersex people are born with sex characteristics which don't fit the typical definitions of male or female. Too often, these children are subject to medically unnecessary normalizing surgeries in order to make them fit into a neat gender binary, which in turn can lead to lifelong health issues. Only 3 countries ban medically unnecessary non-consensual surgeries on intersex children: Malta, Portugal, and Germany. Everyone has the right to the enjoyment of the highest attainable standard of health, including LGBTIQ people. But it is painfully clear that LGBTIQ people the world over do not enjoy this right. We've seen this especially during the global crisis caused by the COVID pandemic. It has amplified already existing vulnerabilities faced by marginalized communities. LGBTIQ people have been sidelined, further excluded from healthcare, and even blamed for the pandemic in too many places. Some of the things that can be done to rectify the situation is for the World Health Organization to strengthen the messaging that homosexuality and trans identities are not disorders and improve their guidance on LGBTIQ inclusive healthcare. Medical professionals who perform conversion practices or non-consensual medically unnecessary surgeries on intersex children should have their licenses revoked. And all institutions that educate medical professionals and the healthcare providers where they work should ensure that medical professionals are trained to provide LGBTIQ inclusive services.
A year ago, we could not have imagined the true impact of COVID-19 or how far we would come in the battle to protect our communities. The urgency to develop a COVID-19 vaccine has led to the mobilization of the largest public health intervention in recent history, an immense effort in the wake of a virus that has spread rapidly with significant consequences. As we confront COVID-19, we must also recognize that we have yet to fully address the simultaneous viral epidemic, HIV/AIDS, that has been ravaging communities and causing devastation since it was first reported 40 years ago. And we must also recognize that in response to COVID-19 and HIV/AIDS, Black people and other people of color are still being failed by our systems and our entire nation. The unprecedented COVID-19 pandemic exposed major health disparities that disproportionately impact millions of Black people and other people of color. These groups are 3 times more likely to become infected with COVID-19, almost twice as likely to die from the virus, and have disproportionately fallen behind in vaccinations. The disparities we are seeing today as we work to address the COVID-19 crisis are unfortunately familiar to those of us working to address the HIV/AIDS epidemic. A look at the statistics tell a shocking story. 1 in every 2 Black, gay, and bisexual cisgender men, and 1 in 4 Latinx, gay, and bisexual cisgender men will be diagnosed with HIV in their lifetime. In the United States alone, 44% of people living with HIV are Black, despite representing only 14% of the population. The transgender community is also disproportionately impacted, with 26% of Latinx transgender women and almost half of Black transgender women in major cities in the United States living with HIV today. Research proves that access to good quality health care makes a positive impact on the health outcomes of our communities. But there is still a gaping need to set an even playing field for people who have had an unfair disadvantage. Critical resources that raise awareness, educate, support, and heal those at risk for and living with HIV, as well as their care networks, are still vastly scarce. Worse, in some communities, they are non-existent. The first step to addressing our failure as a nation is to recognize it. And our renewed national focus on health disparities has brought an opportunity to come together and end health inequities long perceived as intractable. We also find hope with newfound advocates standing alongside us to champion change in this widespread public health issue, including our president and our vice president. To continue building support where it is needed most, the Human Rights Campaign Foundation and Gilead recently announced a 2-year partnership to focus support on the communities that are disproportionately impacted by the HIV/AIDS epidemic in the United States, including Black, Latinx, trans, and other high-risk groups, to increase HIV awareness and available health and support services. We are also working directly with community partners, historically Black colleges and universities, and youth-serving professionals to increase awareness of HIV treatment and prevention options and to combat the discrimination and the stigma that all too often lead to fatal violence against transgender women and of color. We need to build off these critical and current efforts to ensure real change for our communities, whose needs have been overlooked for decades. This will necessitate leadership and partnership at the federal, state, and municipal levels. In particular, municipal leaders have a duty of care to the people that they serve. And to best serve their constituents, they must work with minority-led and serving community-based organizations. These organizations are not only on the front lines of the epidemic in high-impact communities, they're also frequently the point of entry to care. Given their vital roles, these organizations need financial support from municipalities, as well as assistance building capacity, so that they can meet long-term programmatic and organizational goals. In addition, municipalities must leverage relationships with local advocates, other HIV-serving organizations, and LGBTQ centers so that policies are developed with direct input from communities that are being directly impacted. And finally, leaders of all levels must recognize that our work to end HIV and the HIV epidemic is fundamentally intersectional. We will not achieve an end to this disease if we do not address the disease of racism, transphobia, homophobia, biphobia, and classism. We must defeat these forces in our society, once and for all.
I'm sending this message during this difficult time that is experienced globally with the COVID pandemic, where we've seen rise of new infections, where we've seen serious need of vaccination. And even here in my own country, where we are currently experiencing a third wave, we've seen serious level of lockdown regulations enforced because of the infection rate. But also, I think it's a very difficult time in South Africa because for the last 72 hours, we have been experiencing riots, we have been experiencing the rise of violence, attack on infrastructure, on people, and this experience in the last 72 hours have created instability in the country, not only just economically, but socially and politically. We've seen criminal activities that have created a burden on the country, and it's even creating further burden that will be impacting the health system, our already weak health system that we are struggling with. So the serious need of interventions that we've seen by our government and many stakeholders, including communities, have been quite important. But I think also this time in South Africa, we're experiencing even more dire situation with LGBTI situation. For the last 12 weeks, 16 LGBTI people have been murdered, and over 8 reports of those who were sexually and physically attacked. So it is a very difficult time. Here in South Africa, we have the highest HIV epidemic with over 8 million South Africans living with HIV. And LGBTI people are integrated in the National Strategic Plan. We have an LGBTI HIV plan which is a very critical plan that speaks about addressing vulnerability experienced by LGBTI people from biological, behavioral, social, and structural issues. And of course, the report is revealing that LGBTI experiences are at a multiple level. We know HIV responses here and everywhere else only prioritize men who have sex with men, and because they're a key priority. We know that HIV response everywhere else needs to target transgender, in particular transgender women, in the response, understanding the data, understanding the needs to respond, and understanding how access to services can be improved. But the lesbian, bisexual, and others are also left behind. So fast track cities requires us to actually deal with the inequalities, deal with lack of access to services, because it's needed. We must never cost life as we've seen in the past. One of the biggest challenge also speaks to the social challenges here that we also are struggling. I've highlighted the issue of gender-based violence, the issue of hate crime earlier, because that's what we're suffering with here in South Africa. But also its issue of homelessness. So if we're going to fast track health equity, we need to speak about homelessness, we need to speak about hunger, equal opportunity to job opportunities, but also equal opportunity to education, because we've seen quite a lot of LGBTI people dropping out of school because of stigma and discrimination, and we need to address that. At the same time, we need to also address the element of exclusion in the responses. So Fast Track Cities report is highlighting some of these social, economic, and response that is needed now more than ever. I'm quite excited with the report, and I look forward to taking this and using this using the report itself in order to advocate for further inclusion or improvement in programming. I wish the partners that have committed to supporting this fast track cities on LGBTI health equity to continue to do it even at country level, to do it at regional level. That way we will ensure that the equity is what is applied accordingly.
I'm so proud that Bangkok is one of the 11 cities in the Asia Pacific region taking part in the Fast Track Cities initiative. And I thank you to the leadership of the Bangkok Metropolitan Authority for their leadership. Congratulations to Ipac on the launch of the LGBTI+ Health Equity, a global report of 50 Fast Track Cities, and right at the World Pride 2021 as well. HIV remains a significant public health challenge in the Asia Pacific region. The Global AIDS Strategy 2021-2026 notes that earlier gains in the regional response are under threat, with many countries in the region experiencing new waves of HIV infection. In 2019, 98% of new HIV infections in the region were amongst key populations and their partners or clients, and 1/3 of new HIV infections are amongst young people. Thailand has been one of the most successful countries to respond to HIV in the region. According to UNAIDS data, the country has seen a 65% reduction in new HIV infections since 2010, and a 44% reduction in AIDS-related deaths since 2010. And since 2014, everyone can access treatment for free, and people living with HIV are offered treatment immediately after diagnosis. In 2016, Thailand's National Committee for the Prevention and Response to AIDS released a new national strategy to end AIDS by the year 2030. The strategy outlines 3 goals. First one, reduce new HIV infections to fewer than 1,000 cases per year. Secondly, to reduce AIDS-related deaths to fewer than 4,000 cases per year. And finally, to reduce HIV and gender-related stigma and discrimination by 90%. And central to an effective response is ensuring that the voices of people living with HIV and those of key populations at risk to HIV are heard and their views incorporated into decision making. And Thailand is a regional leader in engaging key populations and supporting key population-led delivery of services. For example, peer-led outreach to link key populations at risk to prevention, testing, and treatment services. It is also a regional leader in adopting new innovations, such as pre-exposure prophylaxis targeting gay, other sex with men, and transgender people. Bangkok may be seen as a paradise for LGBTQI tourists, but scratch the surface, then you may be interested to learn that in Thailand, there is no gender recognition for trans people. Same-sex relationship is not recognized by law. Sex work is criminalized, and drug use is criminalized. And these are additional legal barriers for LGBTQI people, which we have seen has been exacerbated by the effect of COVID-19. In August last year, APCOM with 70 organizations submitted an open letter to the World Health Organization aimed to bring attention to the effect of COVID-19 on LGBTQI communities to ensure that the World Health Organization integrates the effect of COVID-19 on LGBTQI communities and for inclusive strategies and responses for COVID-19. As we know, the effects of COVID-19, based on APCOM survey, showed that organizations and communities were concerned regarding the delivery of health services, including HIV-related services, access to LGBTQI people to mental health services, and for those who need them. And these have been affected by the pandemic. These issues are in addition to the stigma and discrimination experienced by service users even during normal times. For Pride Month, APCOM launched a report working with 8 community organizations in Thailand with 1,430 respondents. And we found that marginalized communities hurt the most in terms of their loss of economic incomes, but then are the least able to access support. HIV service delivery is still working due to the interventions from the community-based organizations, though they are already very stretched with limited resources. Mental health needs and issues have been flagged as an emergency need, though mental health services is so limited in our region. The report also recommended to ensure that greater LGBTQI health equity based on our findings are as follows. Investment in the long-term community-based infrastructure and mechanism for HIV and other health service delivery. Secondly, involving the community in policy-making decisions in relation to mental health, HIV program, and using human rights lens for LGBTQI communities. And lastly, invest in a community resilience mechanism so that they are resourced and can respond better to the needs of the community in an emergency setting. As we celebrate World Pride 2021 in Copenhagen and Malmö, I hope that we are also able to advance health equity for LGBTQI people globally. ขอบคุณครับ
First of all, I want to start by congratulating and thanking Ipac for the production of the report, LGBTI Health Equity, a global report of 50 fast-track cities. As a transgender woman living with HIV, the findings of the report are no surprise to me. Rather, they echo the issues I have faced throughout my life and the issues that members of my community face every day. I'm going to touch on 2 issues that came out of the report, which I think are crucial from the perspective of transgender people. The first one is about quality of life. We still have a very long way to go when we talk about quality of life. There are so many issues that are interconnected that affect our quality of life as trans people. These issues, which form barriers for a dignified and high quality of life, include but are not limited to the high levels of violence, stigma, and discrimination that trans people go throughout our lives. Frequently, trans people experience stigma and discrimination from a very early age, and it comes from those we least expected, our friends and our families. Many trans youth are forced out of their homes, becoming homeless, and many of us had to use sex work as a survival strategy. We cannot even start talking about quality of life when we live in a system that doesn't recognize us as equal human beings, as equal citizens with the right to legal gender recognition, and with the right to equal opportunity to labor, to housing, etc. Perhaps in the case of trans people, I can say that if I had to choose the biggest barrier to enjoying a dignity and high quality of life, that would be the lack of legal gender recognition. Not being recognized by who I am and how I identify diminishes our humanity, our dignity, and it drives us onto invisibility. Another issue that came up in the report that I find really important and of huge concern is the issues related to access to healthcare for trans persons, particularly the access to gender-affirming care. It was no surprise to me that participants rated this bad. In most of the world, gender-affirming care is only a dream, and it's very far from being a reality. Only a handful of countries provide gender-affirming care for trans people. And even in this handful of countries, there are so many requirements and bottlenecks to access gender-affirming care that it becomes literally a nightmare for trans people trying to access these services. Long waiting times for up to 2 or even more years causes unneeded stress and mental health issues. They need to be declared mentally ill or to have a certificate from a psychologist or psychiatrist is not only a barrier to access to services, but it also continues pathologizing trans identities and trans people, which goes contrary to ICD-11. I can only hope that in the near future, there is available guidelines that countries can follow and adhere when it comes to gender-affirming care and puts the individuals first, and it's a people-centered approach that moves away from pathologizing and moves towards self-recognition of our identities. Lastly, I want to mention all the other social, political, legal barriers for trans people that impede the access to high quality of life and its enjoyment. Issues like the access to feel equal as citizens in a country that is exasperated by the constant stigma and discrimination from society. The institutionalized stigma from states that criminalize trans identities, but also from the lack of education by gatekeepers. Once again, thank you, Ipac, for producing the report, and I look forward that countries will take action to remedy what has come out of these findings. Happy World Pride 2021.
Health equity is very topical to the work that we do at AIDS Funded, and as health data on LGBT plus people is generally scarce, your report is valuable resources for us in our work to ensure that the fundamental human rights to health, equality and equity can be enjoyed by LGBT plus people in Copenhagen. I'm happy to know that Copenhagen is one of the 2 cities in the health equity report that has the lowest self-reported discrimination on gender identity. Today, the municipality of Copenhagen is the only one in Denmark with an LGBT plus policy, and it has been a strong partner in the fight against HIV for more than a decade. Recently, the city of Copenhagen and AIDS Funded joined the Fast Track City Network, a strategic partnership that will help build momentum in the fight against HIV stigma and discrimination. In February this year, the city of Copenhagen reported on the progress made in the implementation of the LGBT policy, where AIDS Funded's Clinic for Sexual Health Checkpoint plays an important role as far as sexual health is concerned. Checkpoint is designed with the LGBT plus community in mind. It is inclusive, sex-positive, non-judgmental and anonymous. It is a highly specialized alternative to GPs and the general health services. At Checkpoint, we offer counseling and testing to people at risk, and as part of the City of Copenhagen's LGBT+ policy, we have been able to scale up efforts to test more broadly among transgender women and men who have sex with men. In addition to HIV and syphilis, we have also started testing for chlamydia and gonorrhea. This is important to diagnose and treat more STIs. But the range of test options that we have also serves an early warning system for risk behavior. And the sooner we can identify risk behavior, the sooner we can tailor counseling to mitigate those risks. For instance, by starting PrEP. This is what a strong and an actionable LGBT+ policy can do, and Copenhagen has shown the way. When AIDS Funded was founded in 1985, it was on the back of the indignation and the frustration over the lack of understanding that the LGBT+ community was met with in the wake of a virus that had a devastating effect on members of the community. AIDS Funded's primary goal was to make AIDS a priority in all relevant sections of society and ensure that it was taken seriously by politicians, health service providers, and the society at large. And that is to a large extent still our goal. Over the year, our work has changed. Medical advances such as the availability of ARVs without side effects, PrEP and PEP, have transformed HIV from being the end of the line to being something you bring along for the ride. In other words, you don't die from AIDS, you die with HIV. But our work is not over yet. Looking at Denmark's number for the fast-track city targets, Denmark is doing well in 2 targets, ensuring that those who are diagnosed are receiving treatment, and those who are receiving treatment have a viral load so low that they cannot transmit virus. However, in Copenhagen, only 91% of those living with HIV have been diagnosed. In other words, 1 in 10 is living with the virus unknowingly. This is where Copenhagen needs to make the biggest effort. The fact that the city of Copenhagen already has an LGBT+ policy means that we are starting from a position of strength, and that position has been further strengthened by the participation in the fast-track city network. The conducive space for the LGBT+ community that we are building in Copenhagen is also being built in every single fast-track city around the world. There is indeed power in numbers. Speaking of the power of collaboration, I would like to mention the organizers of this year's World Pride Copenhagen 2021. It is a unique event because of the global nature of it as a World Pride, but also because of the strange and uncertain times that it is being held in. The Pride is very close to my heart, and I'm in awe of the tireless efforts and the tenacity of the organizers in pulling this off. They would not let a virus stand in their way, in our way. Congratulations and thank you.
Thank you to all our panelists for their invaluable insights. We will now begin the live question and answer session in which we have 30 minutes to further discuss our report and its findings.